Hi, everybody. My name is Adriana Tremoulet, and I'm a professor of pediatrics at the University of California, San Diego and Rady Children's Hospital. I'm also the associate director of our Kawasaki Disease research program at UCSD and Rady Children's Hospital. So the first part is to really understand what it means to be resistant to initial IVIG therapy. And so I want to explain the definition that has been used for many years and is in the most recent American Heart Association 2024 Kawasaki Disease statement. IVIG resistance is defined as having a fever, which is either 100.4 degrees Fahrenheit or 38 degrees Celsius, more than 36 hours from the end of the IVIG infusion. So what that means is if your IVIG infusion ends at 3 in the morning, the next day after 3 p.m., we start to care about what happens with the fever after that. So if a child is having fever after that 36-hour time frame, they are defined as having IVIG-resistant Kawasaki disease, as long as they didn't receive anything besides IVIG in those first 36 hours. And the most important thing to have happen at that point is to be assessed by the medical team. So kids can come in and they can be diagnosed with Kawasaki disease, but they may have another illness that develops. Maybe they got influenza while they were waiting several hours in the emergency room waiting for admission. So if a child has fever after that 36-hour time frame, what should happen is that your child should be assessed by the medical team at the hospital. They should look to see if there's anything new. Does your child have pain with urination? Are they tugging at their ears for an ear infection? Do they have a new runny nose and have some kind of new cold? If none of that is there, and most of the time, honestly, there's really no other explanation, then what needs to happen is there needs to be a consideration of additional medication beyond IVIG. And the reason that has to happen is because there is potentially an increased risk for heart disease, for the coronary artery aneurysms from Kawasaki disease to develop if there's fever beyond that 36-hour time point. So in terms of additional medications that can be given beyond IVIG, there are two that are really pretty standard and are used around the globe. One is giving steroids, which is used in many parts of the world, and the other one is infliximab. So specifically in terms of infliximab, I'll mention the dose because that's important. It's 10 milligrams per kilo IV. That is the dose that's recommended. In addition to that, it's important to understand that there was actually a randomized clinical trial known as KidCare that compared giving a second dose of IVIG versus the 10 milligrams per kilo of infliximab to children that were determined to be IVIG resistant. And what that study showed is that by giving infliximab instead of giving second IVIG, the kids that got infliximab had a shorter duration of fever. They had a reduced need for additional treatments. They also had less anemia, and they were hospitalized for a shorter period of time. And so all of those reasons are why the KidCare trial determined that if your child needs additional treatment for IVIG resistance, instead of giving a second IVIG, that infliximab should really be strongly considered. It's important to know that infliximab and steroids have actually never been compared to see which one of those are better. But we do know that there are better options than giving a second dose of IVIG. So in regards to IVIG, I want it to be clear that IVIG, a single dose of IVIG is still considered to be the standard of care of treatment for children with Kawasaki disease around the world. And that is clearly been demonstrated to reduce the risk of aneurysms or ballooning of the arteries of the heart in children with Kawasaki disease. In regards to additional treatment that can be given, so if you look at second IVIG versus infliximab, that was really what was evaluated in the kid care trial for children that, again, had this persistent fever more than 36 hours after finishing their IVIG. So it's important to understand what these two products are, what these two medications are. So IVIG is a human blood product. It is given over 12 hours. And the way that it works is by killing an inflammatory cell called a neutrophil that causes a lot of inflammation in Kawasaki disease. Infliximab works a little bit more specifically. It attacks a protein that causes a lot of inflammation in the body and basically takes it out of circulation. So that is reducing the level of inflammation in children with Kawasaki disease. Infliximab is a lot easier to give than IVIG. It's given over 2 hours IV, and it's only given usually once. In regards to side effects, the side effect profile for both is actually really low. But what came out in the kid care trial is that when you give a second dose of IVIG, that your risk for anemia, possibly because of how the IVIG is processed, and based on the blood type of the child, that there can be a severe anemia that's caused by much higher doses of IVIG, which usually happens when you get a second dose of IVIG. So for our families out there, it's important to have a conversation with your provider if they're maybe considering a second dose of IVIG. If your child's blood type is O, then there really is no risk for this anemia. But if their blood type is other than O, there may be an increased risk for significant anemia with a second dose of IVIG, and to have that conversation. Yes, so in regards to your child, if they are in fact IVIG resistant, I think it's important to know that there are other options available. And that if your child finds themselves in a situation where they're having a lot of fever after that 36-hour time point from finishing their IVIG, to really start to ask the team, what is the plan? In fact, I would ask this question from the very start, if at all possible. It's really, I think, empowering to our families and to our providers to know that there's a plan in place. So we all know you're going to get IVIG from the start, but what if that doesn't work? What if my child continues to have additional fever? And this is a really important conversation to have from the beginning, because IVIG resistance is not the only reason that we give additional anti-inflammatory therapy. The other reason, which is really very clearly stated in the 2024 American Heart Association Kawasaki Disease statement, is that if your child has an abnormal heart ultrasound from the very beginning, if they're having already some either swelling or ballooning of the arteries of the heart on that first echocardiogram, that is a reason to go ahead and add additional anti-inflammatory therapy and not wait for that 36-hour time point to come. So there are several reasons why additional anti-inflammatory therapy should be given, and to really have a discussion from the start with your provider and just ask, what other things could lead to more than just IVIG alone? The last group that I want to bring to everyone's attention are infants. So we know that children less than 6 months of age that are diagnosed with Kawasaki disease have higher than a 50% chance of having aneurysms, even if treated with IVIG in the first 10 days of illness. So that's a very high-risk group. Given that, there's actually a move right now that has started, and it's listed in the American Heart Association 2024 statement, to consider in those highly vulnerable infants to give them something more than just IVIG. Traditionally, that ends up being either infliximab or steroids, but to give them something more than just IVIG from the very start. even if they're not having a lot more progressive fever, and in some cases, even if their echocardiogram is normal. So again, that's a shift that's happening. It's not universally accepted, but I think these are things that are important to start to have the conversation, because we're moving now in Kawasaki disease to understanding that by being proactive instead of being reactive, we're going to be able to actually have fewer children with long-term consequences from Kawasaki disease.